To celebrate a Chambliss Faculty Research Award. The Chambliss Faculty Research Award was inaugurated in 2004 through a gift from Dr. Carlson R. Chambliss, Professor Emeritus of Astronomy, who was a member of the Department of Physical Sciences from 1970 to 2003. The Chambliss Faculty Research Award recognizes the very highest achievement in research and scholarship. Each year, up to 2 awards can be given, and the Faculty Research Award can only be won one time in a person's career. Each award has 3 components: a gold-plated medal designed by Dr. Chambliss with the awardee's name engraved on it, a certificate of recognition, and a cash award. We are so grateful for Dr. Chambliss's generosity that allows us to present these awards and to hear about the important work of our faculty. Can I ask that those in attendance who have won the award before rise to be recognized? Thank you. And thank you, Dr. Chambliss, for your support of our faculty. The 2022 recipients are Dr. Laura Sherrod, Professor of Geology, who will give her distinguished lecture in the fall, and today's presenter, Dr. Valerie Trollinger, Professor of Music. I would like to now invite Dr. Bradley Shope, Acting Dean of the College of Visual and Performing Arts, to introduce Dr. Trollinger and her work. My weird life.
So it's sort of fitting that I introduce her today because I have been losing my voice over the last couple of days. It started at my daughter's soccer game, I think, cheering her on. Good afternoon, everyone. It's very much my pleasure to introduce Dr. Trollinger. As someone with a background in music myself, I find her work to be quite unique and interesting. I really do. It's certainly a unique area of research. It's really just fascinating and quite new work. And I'm very happy that she received the Chambliss Award today. Dr. Trollinger has been at KU since 2006. She earned her Bachelor of Music Education degree from Susquehanna University and Master of Music Performance and Doctor of Music Education degrees at Indiana University, Bloomington. Valerie knows that she and I are both alumni of the IU School of Music, Go Hoosiers. An active performer, she has been principal bassoonist for the Reading Symphony Orchestra since 1994. And has performed in the bassoon section of the Philadelphia Orchestra, the North Carolina Symphony Orchestra, and the Aspen Chamber and Festival Orchestras. Over the past decade, she has devoted much of her work to diagnosing, treating, and rehabilitating musicians, especially wind instrumentalists who suffer from vocal and performance issues. While the field of professional voice care has been around for a while, this area of wind instrumentalist voice care is quite new. An active writer and researcher, she has published in the Journal of Research in Music Education, the Philosophy of Music Education Review, the Double Read, the Music Educators Journal, the Journal of Singing, and General Music Today, to name a few. She's published and co-authored and authored many, many book chapters and articles, too many to list here. In 2016, she was awarded a Fulbright Scholarship to teach music, technology, voice, bassoon, and musician health in Malaysia. Please welcome Dr. Trollinger to the podium.
Hi. The reason for the red dress, I represent acid reflux, which is I need a bigger laugh than that from this crowd. Thank you. Yeah. Because that's a big part of what I'm going to discuss today. And instead of getting up here and going through the usual routines, take care of your voice, make sure you get plenty of rest, make sure you drink water. I wanted to take it beyond that. And I wanted to make sure this was practical because professors are one of the groups that tend to have a very large amount of voice issues. Some of it can be career ending, some of it not. Brad, I'm putting you in vocal rest. Okay. And it's not different from teachers in the public schools, newscasters, actors, professional opera singers, rock singers, all sorts of people who depend on their voice for their career. So I wanted to, when the other folks get to see this later, part of this presentation is taking what I already know and how we work down in Philadelphia, but also sharing what happens if you've done all that great stuff and still you're starting to feel like you have a problem. Okay, so it's not doing what I want it to do. Excuse me. And I teach technology too, and this happens. It had been. Let's try again. That's the red light. Did we get, which one did you push? This one on the side? Okay, thank you. Sorry. Okay, so to clarify, I want to make sure you know I am not an MD. Okay, I have been asked at some places for hospitals if I have privileges, and I go, oh, I wish. Okay, but it also comes down to I'm also on the faculty of the Drexel Medical School as an adjunct professor of otolaryngology, head and neck surgery, and I made that red because I have a doctorate in music education, yet I am a professor of surgery, which is what I love. And I'm affiliated with Philadelphia ENT Associates. I will regularly follow my colleagues out of the operating room and I say, when do I get to cut? When is it my turn? When is it my turn? Still waiting. Okay, so the information provided here does not take the place of an evaluation by a medical professional who is highly trained in this area. And I have asterisks there because defining highly trained in this area does not mean this is your regular ENT you go to if you feel sick. This is a different type of person because you are professional voice users. So what this lecture will include, beyond the drinking of water, okay, is the overview of the common problems we find in professors and teachers when they come down to us in Philadelphia, the evaluation of the voice and to not be scared. And I'm sharing the world premiere of my scoping from last week. Okay, so you're going to be the first to see it. Well, no, some others did, but anyway, treatment of voice issues to help ensure a long career. If you are sensing you have trouble, there is nothing wrong with getting help for it because most of these things are easily treatable without surgery. And people are often afraid to go in and think they're going to get cut right away. That is not what anybody wants. Okay, oh, I forgot to say, while I have a wolf there, you're probably wondering, why in the world do I have a wolf here? Because the first big research projects I did concerned wolf voices and wolf howls. So that's my homage, okay, because wolves are what started me down this route. That's kind of scary. Okay, so college professors who teach are highly prone to voice problems. And you probably heard all this before, attributed to overuse. You're talking too much. Overuse plus laryngeal pharyngeal reflux, the reason for the red dress. Okay, your individual anatomy, everybody is unique. I can read in an anatomy book that says, oh yeah, this is here, this is here, this is here. But then when you get someone in an operating room, sometimes you notice something's like moved over like a couple millimeters or something. And it's a surprise. I mean, everybody's just a little bit different and it's not as neat as the books make it look. Okay, so your individuality, pushing through. This is part of being college professors, this is part of being a musician. We push through, we perform, it hurts, we just make it work no matter what, okay? We have to get back to the culture of, no, if it hurts, it's your body telling you, hey, knock it off. This is not good, okay? So a quick tour of the voice. I'm not gonna go into anatomy, okay? But I do want you to see where overuse and issues will show up, and because these are the more common things. So above right, I have the vocal folds up there. Let's see if this little, oh, there we go, okay. Right here, and I call them vocal folds. Well, we all call them vocal folds in voice science. They used to be called vocal cords, which really made no sense. But in the late 1990s, better imaging techniques were available to show that the vocal folds are actually several layers and they roll over each other as they move. Okay, so we call them folds. That's how they behave. If we're going to see injuries on them, we're going to see swelling. Okay, and the next screen will show you what they look like when they're all swollen. And they will show evidence of past injuries, such as hemorrhages, scarring. You hemorrhage from a really bad cough, just one bad cough, and you can bleed in there. Any other past surgeries, any other types of problems, reflux, especially because you will swell. So we will see them there. But the big concerning area, especially for professors, is what we call along the vibratory margin. I do want to clarify, this would be where for the guys, where your Adam's apple is, there in the front. Okay, this is the back. Back here, would be your esophagus. And that's where the acid comes from at night when you're sleeping, doing its bad stuff, because you don't feel it, okay? So vibratory versus non-vibratory. These edges here are the vibration areas. So if you have nodules, cysts, granulomas, polyps, anything happening along there, it is going to affect the quality of your voice. We do have people who come in and have bumps, the non-medical term, of things, but they're not on vibrating areas. So they're not affecting the quality of the voice, but they may affect some other things down the road. So we, of course, keep eyes on that if that happens. Now, down here with the whole entire larynx structure, again, I don't need to go through the whole thing in detail, but this is suspended in your skeleton. It's not necessarily really attached to anything, okay? And the muscles and ligaments kind of keep it where it's supposed to be. You have two main nerves that branch off into 6 other nerves, and they control everything that happens with all the cartilages and the muscles in the laryngeal area. I'm giving you the easiest description I can think of, okay? One is the superior laryngeal nerve, one is the recurrent laryngeal nerve. And the 6 nerves, what they do is they will control, we'll have a pair that controls opening and closing, just basic opening and closing, which you of course use when you swallow. Lengthening and shortening, that's where you get range from low to high. Okay, and then, excuse me, breath control. Okay, so if someone talks for a long time and they're noticing that they just can't do it anymore, okay, that would be a breath control issue. Or someone's talking and they are talking and they're hearing a crack, like they can't get above a certain pitch. That usually means that that has something to do with the lengthening and shortening, okay? But the vocal folds themselves don't, they respond to everything else around it that's pulling it. And it moves in so many different directions, okay? Many different directions. And that's what adds to the complexity and also the beauty of this area, because it is just really amazing. So those are the main things. Those are usually where we will see injuries, okay? So what contributes to overuse over there is the swollen red vocal folds. And if you look very closely, this is the best picture I could find because I didn't want to find something that had a lot of acid reflux, because this is how red it gets, okay, around it, because you'd be so, oh my gosh, as soon as you see that. But what also happens is between some of these layers that run over each other, you can get swelling and liquid in between layers. And here you can see a little bit of grayish all in here, and that's showing the liquid, okay, because of the swelling. So you can have someone who's all swollen up, comes down, put a scope in them, look, and they look like they're getting full closure, except that when we look at them more carefully, we see that no, where they're closing is because of all the swelling, because their vocal fold bands actually are all back here, okay? So people who have this problem, then when they go through voice therapy and they start addressing the reflux issue, they usually start out sounding bad, and they get worse and worse and worse. And the reason is because the swelling's going away, so they're losing the contact, okay? And then they're relearning how to use their voice correctly, so it won't come back. Also, plus not drinking lots of soda, you know, all the acid reflux stuff. I always have to, hopefully none of my colleagues in Philadelphia will see this. I always wonder, why in the world do we get pizza ordered for the entire office for lunch on a patient day? It's like we're just calling it reflux on a plate. You know, like why is this happening? You know, there you go. Okay, so how you get there is talking too much and then coughing after, okay? If you feel something in your throat, the best thing to do is just grab a drink of water, a quick swallow of something, okay? You don't want to keep coughing. That's adding more trauma to the voice. Using the voice to get attention, yelling, okay? That is where we have had people who have done one big yell and they've hemorrhaged, and that's it. All of a sudden they have no voice, okay? Those kinds of injuries, you have to get looked at right away, okay? They're tiny, tiny little vessels, but they do bleed a lot. Not modulating the voice in pitch. And you will hear as I talk, I can go from, I do high and low, and I'm not just doing monotone like the professor in Bueller, okay? Yeah, that is critical to keeping your voice healthy. I've been teaching since 1985. I only lost my voice once. And that was my first week of teaching elementary school. Okay, that'll do it. But I mean, my mother had to call me in sick the next week because I couldn't make a sound. And if I had tried It would have sounded like an obscene phone call to my principal. Okay. But that taught me, and her being a professional singer as well. So I was able to get on board with a lot of the strategies. And actually she threatened to, she said, if you don't get better, I'm taking you down to see Dr. Saddlehoff. And I said, no, I don't want to see Dr. Saddlehoff. I ended up down there anyway, 25 years later, because that's where I work. But I haven't lost my voice. And modulating in pitch, as soon as I start feeling like I'm tiring here, I put my voice up. Okay. And there's a strategy I'll show you when we get closer to the end that can help you find that too, if you need that. Not drinking water to stay lubricated. Of course, that's the most important. Caffeine, alcohol, all the stuff we like to drink during class, caffeine, alcohol, is going to dry you out. Okay. So we don't want to do that. Not resting the voice as needed. That is critical. Okay. We had a patient who came in last week and said, you're on voice rest right now. He hemorrhaged. He had a big mess going on. You're voice rest right now. Oh, well, what about this? You're on voice rest right now. But I want to talk about you're on voice rest right now. They just could not get him to shut up for the next 2 hours while he was there. He said, you can't talk, okay? Because he was compounding damage. And then here's the other big thing. Laryngeal pharyngeal reflux, LPR, also known as silent reflux. You don't know you have it if you have it, okay? You don't feel it. And the reason you don't feel it is because it mostly happens at night when you're asleep. It spills over from your esophagus onto your vocal folds and the area around it, and it burns, it's acid, okay? And the reason you don't feel it is because with so much acidic activity, you've essentially burned out all of the sensors in your esophagus, so they don't feel it. And so when people finally realize they've had the test and see that, oh yeah, you had 550 episodes of reflux within 24 hours, okay? And they start going on the medicine and how to take care of all that. And then they start saying, but now I'm feeling it. And it's like, well, yeah, that's what you want to feel. That means everything's healing. Okay, so you want to, when it happens, you want to feel it and know it's happening. So if you take, say that you've developed nodules, which I'll get into briefly. That's a very common problem you run into with teachers and singers. If you ignore it and say, well, I'm just going to let it wait it out. But if every night you're pouring acid on top of it, it's just making it worse and worse and worse and worse. So they're going to just keep swelling and getting worse. So the whole snowball thing happens. And this is why I wanted to do this particular presentation, because I want to take the fear out of what, getting rehabilitated is like vocally, if you have trouble. So what it does is it's acid from the stomach that reaches the vocal folds. It spills over from the esophagus. Okay, and it commonly happens when we are asleep. Again, common symptoms of it include waking up with a lot of throat clearing and a lot of regular throat clearing and especially bad breath, which my lovely illustration shows you there. Okay, that's usually a sign of reflux if your breath is bad, not necessarily bad oral hygiene because it comes up from somewhere else. Dogs have the same problem. Okay, I've tried to put our one dog on acid reflux. He's not going to buy it. So the reason why it's a problem is that if acid is put on the vocal folds, they will not heal from any other type of trauma, and they actually are going to get worse. Then the person who suffers then overcompensates how they're using the voice, and that just makes it even worse and adds more swelling, more problems, and it just keeps getting worse. So common diagnoses for professors with voice issues, aka known as dysphonia. We just found out that who's the actor who just was diagnosed with aphonia? Bruce Willis. Okay, yeah, aphonia. Well, that's just an indicator of something else happening in there. Okay, aphasia by itself isn't just a disease that attacks. We call this dysphonia, bad sound, incorrect function. Nodules. Take the mystery away from nodules. What they are two hardened spots. Okay, two hardened area. And every time you have something growing on one side, you're going to develop a contact injury on the other side because your vocal folds are slamming together. So the other one just starts building up problems too. Okay, so these are hard contact areas. They're happening here at the opening. So that means if I were to put my finger in between the vocal folds down there, it works like acoustics. It's this whole area up here would not touch. So there's loss of range because only a tiny bit is happening. We usually see the midline, at least from what I recall, midline down through here. You rarely would see them up here because we have a little gap that just doesn't close when we speak or sing. So they always are in pairs, okay? But you can have a cyst on one side. You can have a granuloma. That's part of what happens with acid reflux. It's another type of bump. Okay. But if it's on the vibrating area, it's going to constantly hit the other one, and it's going to cause an injury on the other vocal fold as well. So nodules are always in pairs, and the other one, cisgranulomas, can occur anywhere in vocal folds. And we have so many younger patients who, I guess, who kept watching Pitch Perfect or something. They just keep coming down saying, do I have nodules? Do we have nodules? And we're looking, it's like, no, you don't have nodules. And then we just leave it there and say, no, what you have is much worse. So we're going to wait for the doctor to come in to tell you what it is, okay? Because, we can't say anything when we're watching, but they're always worried about its nodules. Nodules are easy to take care of. Okay, unless they're a particular type, which I'll discuss later. Hemorrhage is the sudden blood vessel burst, often results in a sudden voice loss. If you find you have to go to a laryngologist and get checked, you can see on the vocal folds areas where you've already had trauma, and they're usually yellow because it means it's healing. Like a bruise, when bruises heal, they get yellow. You'll see the same on your vocal folds, they'll be yellow. And also you want to make sure that all of the vessels are running straight up and down. When you see one starting to turn to the side, that means that it has found a growth, it's found something else there that it is feeding a blood supply to, okay? And that's the kind of stuff we look at very carefully. So laryngeal nerve injuries, these can be a result of an accident, a hard hit to the neck, a hard cough, one cough will do it, can do it, okay? As again, because a virus, we're finding a lot of people coming in who had COVID, who now have nerve problems in their voices, okay? We find that by sticking needles in the neck and checking, it's a laryngeal EMG. So the nerve injuries, there's 6 nerves, anything can happen with any of them. And you have one especially that just like, this is what is so great about the human body, is that you have one nerve that just wants to go down underneath your aortic arch and then come back up. It's a really long nerve. So it's prone to damage. It's like, well, why is it doing that? That's just how the body is. Okay. So when our doctors say you need to be scanned below the aortic arch, and then the hospitals don't pay attention and they miss that, they have to go back and do it again because they're not used to doing that. But I keep saying below the aortic arch. So if you ever have to do that, make sure they do it below the aortic arch. Okay. All right. So okay, so treatment for these common problems that professors have. So say that you've done everything and you're really starting to have trouble. Voice therapy always is the first step. Cannot emphasize that enough. Now, do all ENT laryngologists agree with that? No, there are some who are just going to cut. That's it. They said, I have it. I think I have it here. Yeah. But surgery is not the first step. Okay, many other things are. So the exception is a particular type of nodules called bamboo nodules, which I just learned about. They are connected to autoimmune disorders, which is something else we're also seeing a rise in. Okay, so those are a little different story. Cysts and granulomas and other bumps can benefit from voice therapy. Okay, usually the therapy itself will not get rid of the cyst or the granuloma unless it's excruciatingly tiny. Okay. But it does help the patient learn how to use the voice correctly. So when the surgeon has to go in and finally take it off, they have learned how to use their voice correctly, that the injury won't come back. We don't want repeat offenders in laryngology. We want people to heal and go on with their lives. We do not want them to have to keep coming back. You're all familiar with Adele? Okay, Adele constantly has to keep going. As last she reported, and she's been talking about, she talks about it, she gets polyp surgery in here. She's working with a very famous laryngologist, but his view is cut it off and then deal with the rest later. So she keeps getting them back. I don't know if she's had voice therapy. Okay, but these things should not be coming back. Some of these things, okay, mostly. The therapy helps the problem to not come back. There you go. Dr. Sadaloff, who I work with, he tells the patients, he says, you have to do the voice therapy. He says, because I don't want to take you in the operating room, fix you, and then have you ruin my artwork. Yeah, I mean, that's how he says it, by misusing it again. So Julie Andrews, we all heard what happened with Julie Andrews. That's kind of like the poster child for what happens when you go to the wrong person. Okay, the colleague I work with Dr. Sadaloff, he testified in her lawsuit against her surgeon for for the problem she had. And that's common knowledge too. I'm allowed to talk about that. It's not a HIPAA violation. She had, back in the 90s, she was diagnosed with a non-cancerous cyst. And she had a procedure. She didn't have therapy. She just had something called vocal cord stripping at the time, which is not done anymore. They just took off the entire layer of her vocal fold. And you all know now what happened to her voice. Okay. Paresis. Paresis is a type of paralysis, but it's very minor. Okay. But with the voice being as the way it is, it can very easily affect your ability to make sounds. So you can have a nerve that's only functioning 80%, and that still will affect how you feel when it comes to making sounds with your voice. So that's why we do laryngeal EMG and check with needles to see what is being recruited and how much it is being recruited. So voice therapy is done with all, whether or not surgical intervention is indicated. We always, for our patients, we want to get them into voice therapy, unless they're in for a serious medical cancer surgical reason. They go see a different specialist, because we work with professional voices where I am. Okay, so when you notice the following, Brad, pay attention. Voice fatigue, loss of range, cracking, okay? Voice cuts out. You lose your voice fairly frequently. If this is something that just is rare and very rarely happens, that's one thing. If it's something that starts happening more and more often, you're just piling damage upon damage upon damage upon damage. And then it can become a real issue for you. But if it continues for a long enough while, and you know it may not be because of allergies or something, postnasal drip, something like that. If it's really just not getting better, you do need to have a comprehensive evaluation. And this is where things get tricky. It is better and cheaper to address these problems before they get out of control. Cannot emphasize that enough. And these evaluations are not that difficult. This is where people get afraid. They're going to put tubes down my, they're going to put scopes in. Yeah, you're numbed up. You're not going to feel it. Okay. All right. So I had to, okay. I know guys like this. That's the problem. This is where it gets tricky, of course. You need to go to the right kind of laryngologist for this. One who specializes in the voice and really knows the voice. Your garden variety corner ENTs do not have this training. Okay, they simply do not. They don't understand the professional voice. And there are not as many people in this field as there need to be. A regular ENT is not the person to go to. Okay, your professional voice users, you got to go to someone who really understands what you're doing. They will pop in a rigid scope, have you go E, and then say, oh, you have acid reflux, and then send you on your way. Okay, that's not comprehensive at all. That is not enough. Most of them will not look at important vocal behaviors because you have to get a bigger picture of what is happening in there, not just look for reflux. Or I think we had a local music teacher, okay, and I will never forget this day, who did this. She went into a local ENT up here, and she had a granuloma, and that was a big honking thing. I mean, my gosh, that was flapping in her vocal cords back and forth. It came from a sudden yell. So it developed very suddenly. The doctor told her, he said, if you come back Monday, I'll cut that off for you. That's what he said. He said, come back Monday. And that's when she went, okay, I think I'm calling Valerie. Okay. And then we got her set up down in Philadelphia. And then she went through the process of being rehabilitated. And she sounds fantastic now. But if she had just gone and had it cut off, she would have scar tissue. She would have had all sorts of other problems. Okay. But in Philadelphia, she went through the routine because I've been trained and educated by a laryngologist who also has a doctorate in music. And his is in vocal performance. He's got the most gorgeous voice. He would have had a career as a professional singer. Stunningly beautiful baritone voice. Okay. So he really understands voice. He's the only doctor in the world who has this. He has a DMA and an MD. Okay. We always wonder what's going to happen when he finally leaves us, or what are we going to do? So he's very, very picky about everything with the patients. If you want comprehensive care, you get it down there, okay? Most laryngologists who do fellowships, and I'm going to explain what a fellowship is and why you want to look for a fellowship-trained physician, who have done these under him, follow the same process. And I have asterisks there because, well, I will at some point, maybe I took them off. Fellowships are critical, okay? Where they had them, who they had them with, and what they did. We usually get the problem cases in Philadelphia. You've heard of primary care conditions, physicians, okay? Then you have your secondary. We're considered quaternary. So we get the real problems, the ones that they've gone through primaries and their doctors can't figure out what's happening. So we get the real problems down there. And then plus we get kids who have just, I want to sing on Broadway, 6 years old, you know, we get those too. So we usually get them down at Philly ENT because their doctors couldn't figure out what was going on. And I work with a master diagnostician. Okay, and he's taught me a lot about it too. So why is a fellowship important? Okay, as someone who has a degree in education, which Dr. Ward will appreciate, is that I see this is how I see it. Okay, and I don't even have this up here. I see interns as people out on field experience. Okay, residents are student teachers. That's what they are. They don't know everything. They really don't. Okay, in ENT, they have a residency of 5 years. That's what they have to take. But the residents usually do not get specialized training in working with professional voice users. They don't get it, which are singers, actors, teachers, professors, on-air newscasters. Many of them actually have bad vocal habits themselves. Okay, and one time I did say to Dr. Sadaloff, I said, how are you going to address the girls who are scoping people and modeling really bad vocal behaviors? And he didn't say anything. Okay, because I'm going, how do we fix this? You know, they're going to work with voices and they're modeling bad behaviors, and it's mostly the women. So our residents, for example, they are only with us at Philly ENT for 4 months out of 5 years. That's not enough time. The rest of the time they're cycling around to other hospitals. CHOP is popular because that's like a factory, because it's all adenoids, tonsils, and tubes, you know, and that's what they do. They don't even get enough. Okay, but imagine for the residents who are in different places where they don't get any of it. Okay, so there you go. So a fellowship is where the additional intensive training takes place. And only certain fellowships are in certain practices. The one we have in Philadelphia is extremely competitive. We have people from all over the world who want to come in and work there for 2 years. Okay, the first year is mostly observing and doing research. The second year is when they're actually doing more work with the patients. Okay, but they're getting all the secrets. You know, what to look for. How do you notice? What do you see? Okay. All the stuff the nurses do, but they keep their mouth shut because they've been there for a long time, so they know. And there's still not enough of these available. And the reason this is critical to you as a professional voice user is your level of care and your detail of diagnosis, how carefully you're going to be looked at. So I have contact info for physicians we actually have closer in this area who you should consider going to if you have a problem. Okay. Because they will do the correct type of evaluation you need. So what is the evaluation? A comprehensive, there's me. There you are. Isn't that beautiful? I think that should be my new faculty profile picture. So a comprehensive evaluation includes a nasoendo and rigid scopes, 2 scopes. Okay, the nose one only is done only once, okay? Because that's going to see, as you'll see here, it shows how everything is moving inside, okay? And you only really need to see that once. The other one, the rigid, which will be on the next screen, is a better color and shows where there are other problems. Plus you can also bring in the strobe and slow everything down to see what is really happening and where it's happening. So there you go, the nasoendo pharyngeal scope will help in diagnosing issues in movement with the vocal folds. That's mostly going to be nerve damage. It's going to let you see where that is, and the muscles as they work. And then the rigid scope provides the close-up view of the folds as they move in slow motion and better views of reflux damage as well. It comes up like this on the rigid. Okay, I mean, it is fire engine red. So over there, we have the simple nasoendoscope, and this is me. And the reason why we're doing this, why we did this, is to give you a little background, is I had the cold that just would not go away. And last month I asked my colleague Geeth Al-Nouri, who's one of our other physicians, he was a fellow and we loved him so much that he was offered a job there, and I'm so grateful for it because he's fantastic. I really didn't want him to leave. And he looked in my nose. He also had gone through a fellowship in rhinology, you know? So, I mean, this is a super qualified person here. And he looked in my nose and he said, oh, he says, you have a sinus infection. He says, you have a really bad sinus infection. Okay. And because I'd been going through issues, he put me on the medication that cleared all of it out. But to make sure I didn't do anything worse, okay, we decided let's just do the exam. And then the part you didn't see here is we're also doing another research study. So I played my bassoon and trumpet just to see how my vocal folds are moving and stuff. You won't see that part here. That's for our research stuff. So it's very weird playing with that scope down your neck. The first thing that is done is you have numbing spray put in, okay? And that is all the white stuff you're going to see. That's the numbing spray. It's not snot. Okay, just wanted to make sure you do. That is that's the numbing spray. So you'll hear me, and you're also going to hear Geeth talking. And I think Stephanie comes in with something in there. She's the PA.
317. Valerie Trollinger, 317, 2022.
The ugly spelunking. I'm letting you see the inside of my nose. And then I'll stop it when he actually gets to my, there we go, almost. There we go, there's my epiglottis. That looks like the wave. And then this is the epiglottis, and mine just kept wanting to get in the way. Okay, so he had to angle around. And then right behind it is going to be my vocal folds.
Out.
Okay.
Back. Say E. Sniff. Keep going like. Say E and the sniff.
Now what to watch are my arytenoid cartilages as they move. With people who have nerve damage, we'll have one that goes and it starts and then it just kind of stops and the other one's doing the other work. Okay, that's the nerve tires out, and that's why I keep doing. We do these things and I do them fast. I say paraka 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 paraka, you know, just as fast as possible because he's looking to see how everything's moving. Fortunately for me, he did not see any paresis. We've seen people who've they're not paralyzed, but like it's like the other side just gives up. Okay, and then sometimes the other side decides, okay, I'm going to give up. And we had a young instrumentalist, a saxophonist, which showed something that I had never seen. No, I had never seen before. Neither had Geeth when he saw it. Is that when she played sax, because we scoped them while they're playing their instruments, she actually had one vocal fold that moved over to the whole other side, and it was like it was watching the other one work. It was the weirdest thing. It's called posturing when it does that. Yeah, and it was really funky. So here you go. You can see how I am moving. I am healthy. I had no problems. I don't have reflux.
E.
Okay,
that one. E. Okay. E.
Say E. Say patika patika patika. Say happy birthday.
Happy birthday to you. Happy birthday to you. Happy birthday, dear. Yeah. Happy birthday to you.
Very good. Right. Let's do the playing.
Okay, yeah, he was pulling it out. Yeah, and then he had to hold it, keep it in there while we were trying to get trumpets and bassoons up. So it was a real circus. Okay. Any questions on anything you saw? Yeah. Now you didn't see any because unfortunately I didn't have any. And I also don't have any reflux, which I was grateful to see. I made them turn off the camera, the screen across from me, because I said, if I'm watching myself, I said, all I'm going to do is try to diagnose. And it's the screen that has some stuff burned out. So everything looks like it's Martian green and red. Nothing is its regular color. That's like really weird. So anywhere. Oh, okay. So those are what came up. All right. So I had no idea it was going to come up after you saw that. Now this is the rigid. The rigid goes through the mouth. For people who are especially gaggy, they get to be sprayed with a lovely banana, so-called banana flavored stuff that everybody hates. I've desperately been trying to find Minions stickers that say banana to put on these, you know, just to see what happens. But what the rigid scope does is it allows the folds to be observed using strobe lighting, and the speed can be changed. Okay. So this is a healthy voice. She also does not have reflux. You can go online and just search for them on YouTube. Everybody, a lot of people like to put their scoping exams up on YouTube. Okay. So if you really want to see what they look like. So here we go. We have a female singer here, and you're going to hear Dr. Sadaloff giving her directions on what to do. If it loads. Come on. There we go.
A little higher pitch, please.
Notice the folds are longer now.
Slow motion, please. Good breath and a nice steady one. Take a good deep breath.
You see how they roll when they come to that's how they're
Do that
supposed to
again. I'm going to change positions. Speed. B again. Change position.
Okay, there you go. Oh, my dog. Okay. All right. So that's the rigid. In this light in here, it didn't show up as bright, colored. You can't use it. Still looks a little light in here, but when you're seeing it on the screen down there, it's very bright. So, okay. So overall, if you get a voice problem addressed early and go through the process of a thorough diagnosis, voice therapy if needed, okay, outpatient surgery if that is ever indicated, because they're all outpatient surgeries for voice, you can be perfectly fine. And actually, most of our patients come out of it much better on the other side than they were when they came in, which is what we hope. Okay, the process to do it well takes up to a year, a bit more. If you have an issue, you're going to be going through therapy and checkups and everything, and it does take time to do it. It's not you come in, you have one checkup, and you go through like one voice therapy and you're done. Okay, that's not going to help. We once had a broadcaster come in and demand a surgical procedure. And he just went, no, we're not going to do that. If you're going to want that, you have to go through the therapy and the process for it. So obviously that person, she left. So if you have surgery, then it is going to be a bit longer for various reasons, but it is not, you have surgery and all of a sudden, oh my gosh, I can't do anything now for 6 weeks. It's not like that. So if you've waited the long time to be seen, or something else has happened in the meantime and you go, okay, this is really bad, I've got to get this looked at. So what are things that can make you a candidate for something that's gone wrong? If you had surgery and you're intubated, okay, and the anesthesiologists love the biggest tube they can possibly ram down your throat, okay, and I watch intubation when it happens, and they're making sure it gets down there, okay. They use size 7 is the general size. Okay, we use size 5s because we're finding out it's smaller and it will tend to be less of a problem. But if you find out after 10 days, if you were hoarse when you wake up after surgery, that's very normal. But if after 10 days you're still having voice problems, you may have had an intubation injury. So you want to get it looked at to see if something happened that way. That's when you want to check. You went to someone who cut first. You went that route. And you had no therapy afterwards. That can be a problem. You've had other severe injuries, a stroke, cancer, thyroid cancer. Your nerves run through your thyroid through your gland, and when that has to get taken out, there's a big risk that those nerves are going to be cut. And Dr. Sadaloff shares this with all his patients with us. That's what happened to him. He had thyroid cancer. It had to be taken out, and his nerve was damaged. Okay, and he's done many things to get his gorgeous voice back to what it was, okay? But he can't sing Handel anymore, okay? So if you have thyroid cancer, that is a concern. Parkinson's, essential tremor, the development of vocal dystonia, if you're familiar with Diane Rehm, who's on NPR, she had a very distinctive voice because she had focal dystonia, and it's just her voice was not quite working the way it was supposed to. I do know how that's surgically fixed. I'm not going to tell you about that one, okay? Or any other neurodegenerative or connective tissue disorders, which include autoimmune disorders, okay? And these are often due to nerve damage or scarring. Depending upon the problem, they're often addressed similarly to the other previous issues where we had lesions of all sorts. But there's more testing done, a whole array of blood tests, lots of scans of the head and this area especially. Checking your hearing, because you'd be surprised how much that is connected to what happens here. Everything is connected, okay? But it's just more detailed to get a comprehensive picture. I work with a person who will not make a diagnosis until he has all the parts in place and knows, okay? He's not going to be like someone who will see someone walking down the hall and say, oh, you have Parkinson's. I can tell just by how you walk. I know a neurologist who did that. Okay, never saw that neurologist again. Okay, so, and there's so many things that are so very complex with all of this that can be addressed. But that's not what I'm going to do. I'm not going to get into this super complex stuff. So if time permits, okay, what kind of surgical procedures are commonly done? I do have a video that shows one if you want to see it, if we have time. They're all outpatient. That's the first thing, okay? You're not losing weeks and weeks of your life with this. I'm not showing pictures of these right now because some of you have weak stomachs, okay? And I'm going to be respectful of that, although I can sit here and watch them and like eat lunch now, you know, it just doesn't bother me anymore. Mini or micro flap excisions, if you have a cyst, you know, he goes in there, cuts a little flap in the one layer, folds it over, takes the cyst out, folds it back. No stitches, it'll heal by itself, okay? And these are teeny tiny little instruments. I mean, they are so small. And that is what we call cold tool surgery. And then we have lasering, the hot tool surgery. And that's done for engorged blood vessels that shouldn't be engorged. That's usually what a lot of that is. And then we have injections. We can have synthetic materials where Juvederm or something can be injected into your vocal fold, and that will plump it up and help everything come together. Now they do eventually wear off, so people have to go back and get them again, but it's longer to get people under anesthesia than it is to actually do the injection. Okay, you know, once they're injected, they're done, they're out. And we also use your own fat. So you kind of get free liposuction, okay? You know, you harvest fat from the tummy, you clean it up and make it really nice, and then you put it in the syringe and needle, and then you put it in the vocal folds because your body won't reject your own fat, okay? And that will help with some of that too. And these are so common. These are very commonly done. A thyroplasty, what that does is that is where you would have a procedure where you are awake, but you're very sedated, okay? And the reason you have to be awake is because as the Gore-Tex is put in, they're very small pieces of it, what it does is put in your cartilage and it just moves everything over. And he needs to hear you talk and sing to make sure he's got the right amount in. And if it's too much, it takes them out, okay? So you're awake when this happens, okay? And this is the Gore-Tex that we buy in our sports equipment. It's the same stuff, okay? It's just sterile. There you go. So, and that is a cold tool. And cold tool versus hot tool, there's our different schools of thought as to what is better. Most of it depends upon the surgeon. There are those, some really famous voice surgeons, okay, many who show up in the news, okay, who do cut first. They're a surgeon first. They don't have, they're not singers. They're not singers. They never studied voice. So, but they cut first. And they will cut first, and then others will go through therapy first. But there's always the issue of scar tissue because it's going to happen no matter what. And it's usually inevitable, but it depends also how upon one person heals, how you heal yourself. You have people who barely scar, and you have people who are like, oh my gosh, they throw up a whole ton of scar. Okay, then you have to deal with that, and there's no way to predict. All right, so how to stay out of trouble. There are basics. Stay hydrated. That's always the big one. Not caffeine, not alcohol. Modulate the use of your voice. And what I taught myself to do when I was an elementary school teacher is when I started noticing myself fatiguing at the end of the day and going down like this, I said, excuse me. And I would yawn. And where you yawn in the morning, where you wake up, that is where your vocal folds are being set into motion with the least amount of energy required. So that is the frequency you want to aim for, that pitch. It's usually higher than where we usually talk, but you notice I was down and then I put my voice back up, because I noticed I was starting to go down too much, so I had to bring it back up. So you aim for where that is, and that takes a lot of stress off your voice, okay? So I voice tired after a lecture. I gave all of my students in choral methods this semester a cup and a steel straw, to do what we call cup bubbles. Some of you may be familiar with this. You put water in the cup, just a little bit, and you put the straw in and you very gently blow. But that releases like so much in here. And the reason I got them for them also was for vocal health, but also because they were going to be coming to me in choral methods from brass techniques class. They were going to be tightened up the wazoo, okay? And I wanted them to be able to relax some of that before they got over. So I said, yeah, use it as you're walking from Old Main over here to Schaefer. None of them did. But when people started running into trouble, they knew, and they did take them, put water in the straw, and they started doing that. Okay. We also use it for brass instrumentalists as well. But it really does relax a lot because you can't blow hard. Okay. Take breaks as needed. Do not overuse your voice. In college, we kind of get the, we always have the feeling we have to lecture the entire time. Let someone else do the talking. Okay, give yourself a break. Other lecturers, like I'm thinking, if I'm talking about the research of so-and-so in a class, and that researcher actually has a YouTube video discussing their research, hey, I'll let that explain it. I'd rather have it come from the person who does it than me paraphrasing, but it gives me a chance to, chill out here. We of course assign student presentations using nonverbal cues, which is something most college professors don't do. But like with my kids, first day of class, I could just walk in here and just go, and they automatically responded back. You felt the urge, right? Nonverbal cues, because they had to clap back the pattern, and they're all taught that in elementary school. Okay, they will, if they got it ingrained in them, it's going to be hard to keep them from doing it. They're going, how it felt, right? You really wanted to do it. Yeah. So, nonverbal cues to get attention instead of yelling over the class, to get them, everybody settle down, let's get started, and all this kind of stuff. With the younger kids, we always use, quiet fox was a big one, peace sign, all sorts of things. It doesn't have to be like that. Flashing lights on and off, that's not good at all, especially when you have kids who are very sensitive on the autism spectrum. Okay, so we don't do that. But any type of cue you come up with to get everybody saying, okay, we're ready to start, let's go. That is one of the best things to do. So let me see. Okay, yeah, don't worry, I have it. This is, how are we in time? How am I in time? Because I can't see a clock up here. Oh, okay. Well, this, I'm only going to show you the first part. Now, what I do want you to know, okay, it was supposed to go right to it. Excuse me here. If it doesn't come up, it doesn't come up. Yeah, they've decided because it shows surgery that kids can't see it. So it's, this is a video that is out. This is not proprietary. I'm not showing you something secret here. Okay, so we're gonna have this. Oh yeah, if you want to hear really bad singing, this is the stuff you look at. Because I think it's like all about how they look, not how they sound. Oh, I just saw it. Here we go. Okay. How old am I? My phone ringing up there. I have to what it? Okay. Oh, we just went on a severe thunderstorm watch. Okay. Oh, sorry. Right, you're right. Come on. There we go. Okay, I'm going to type this, so don't share it with anybody. All right, here we go. This is a minister. We got a lot of ministers and cantors as well. And you're just going to see this is what we do in Philadelphia.
minor key, beautiful, pensive.
In the bleak midwinter, frosty wind made moan.
I am a minister, and I have been a minister for 38 years.
Water like
We'll only
a
see part one.
stone.
I have always been able to rely on my voice, depend on my voice. It's never let me down, until a couple of years ago when it began to fail. I've lost many notes off the top range. I just can't reach notes. As a matter of fact, I actually had to cut a piece of the service out where I would have sung a solo piece because I just couldn't sing that piece of music.
Let's see what's going on. Yeah, your nose first. Is one side better than the other? Do you know?
Yes.
The examination we perform for patients with that kind of problem involves placing a little scope through the nose and another one through the mouth. Whistle Yankee Doodle. Yeah, that's a reasonable facsimile.
Vocal folds are supposed to close and touch, actually, like curtains in a theater, on a stage. My vocal folds did not close. The effect of that is like having a hole in the sail of a sailboat. It takes twice the wind to move the boat.
Deep breath. Say E again and keep it going when I suddenly let go. Relax. Do you hear the difference in the strength when we bring your vocal folds closer together? Do you hear it get breathy when I let go?
Yes.
We also test nerve and muscle function. We do that in collaboration with our neurologist, Dr. Stephen Mandel, who performs a test called electromyography. Laryngeal electromyography involves placing needles in the laryngeal muscle and having people talk or sometimes sing. When people try to use their muscles, the nerves make the muscles fire, and Dr. Mandel can measure electrically whether they are firing at full strength or whether they are partially weakened or even completely paralyzed. Mr. Mann's laryngeal electromyography showed that our clinical impression was correct. In fact, he had some weakness in the nerve muscle complex, and that was the reason that he couldn't close his vocal folds with sufficient force and firmness to be able to project what he needed to project from the pulpit.
I'm going to play them, you're going to sing them. This is real silly.
Okay.
But I'm going to play Three Blind Mice, and you're going to sing for me.
Three blind mice.
You do it.
Three blind mice.
Yeah, play the chord.
So Dr. Sadaloff then prescribed for me a period of therapy to see if the voice therapists could get those vocal folds to close without surgery.
Now, I want you to try the same thing again. Comfortable?
Yeah.
It's sort of like physical therapy for the voice. It involves exercises and training of the speaking voice, and that includes training the muscles of the abdomen and back, the way one uses lungs in order to use the voice efficiently. We have also used singing training.
Yes, sir. You're so loose.
As it turned out, after a month and a half, perhaps 2 months of therapy, it became evident to them that therapy alone was not going to solve the problem.
I think in the long run, we're going to end up bringing your vocal folds close together.
Surgically.
So the question is whether you want to just see if you can prove me wrong and give it another month with the voice team. I'll tell you what I think we should do. I think we should schedule you for surgery in about 6 weeks. Let you work with the voice team. I'll see you again in another 4 or 5 weeks. And if you're making real good progress, we'll cancel.
Hide your eyes if you don't like surgery, that's fine. Hahnemann
Let's get the
Hospital.
show on the road. Unfortunate that skin crease is so high. We use it anyway, so he looks good, but it's going to make us work a little extra harder.
In order to bring the vocal folds closer together, we make an incision and move tissues out of the way to give us access to the larynx or voice box.
We'll put the self-retaining that way and put you guys the other way.
After we move the tissues aside, we measure the place at which holes should go in the laryngeal skeleton or voice box in order to allow us to insert Gore-Tex, the same material from which ski parkas are made.
That's inferior border.
After we drill holes, we elevate the tissues so the Gore-Tex can be
He'll stop
inserted, and we do
eventually.
this with the patient awake so that he can talk to us and we can adjust vocal quality.
That's the spot right there. In young people, you hardly need a drill at all. On, please. In older males in particular, the cartilage turns to bone. It ossifies, and it requires off tooth. That should do it. Requires a lot of work to get through. Relax. It's going to be a struggle.
And he's awake during this. You don't feel it.
Open up both of the implants. All right, good. We are there. Put your head straight again. Now, Mr. Mann, count from 1 to 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Implant, please. We'll do the right side first.
That's the Gore-Tex. And it folds up like a little
You're
accordion.
going to feel a little bit of pressure. Mr. Mann, your voice is being more finicky than most people. Take a nice deep breath and count from 1 to 10.
1, 2, 3, 4, 5, 6, 7.
Words.
But all turns into fine tuning.
I'm going to try something a little different.
I promise he'll stop.
Now let's see if this makes you better or worse. Do it again.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Yeah, and we all listen. We all listen to kind of get an idea, you know, and often he'll say, what do you
need to take
think?
a
Because
little
he'll look
of
at me and
that
say, what do you
out.
think? Because I'm a
Relax.
voice person.
Now count from 1 to 10 as loudly as you can.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Before I make any more adjustments, how does that sound and feel to you?
I'm exhausted. Why?
Well, what do you think of your voice? Try again.
1, 2, 3, 4.
What do you think of that voice?
Well, that sounds okay.
Sounds okay to me too. Sing happy birthday again.
Happy birthday to you.
Keep going.
Happy birthday to you. Happy birthday,
I think we're there.
dear Robert.
Does that sound more like your old preaching voice?
Yeah.
Well, you made me work for it, Mr. Mann. His vocal folds had a little gap. They didn't quite touch. What we did to help him surgically was a procedure in which we place shims, little space fillers, between the skeleton of the voice box and the soft tissues so that the vocal folds are
Listen all
moved
over.
closer together. There's just more
And
filler
that's what it does.
between the skeleton and the part that talks.
What do you hear him after this?
Everything went fine.
Good.
He was lots of work. He bled a little bit more than usual,
Oh,
just made
really?
it nothing serious, but
Yeah.
inconvenient. And he was also much more sensitive than most people to very minor adjustments. I had to put prosthesis in and take it out on both sides several different times.
Really?
So if he heals without shifting it any place.
We're in
Okay,
good shape.
so he needs to take it real easy.
Okay.
As much as possible,
Define
minimize
real easy.
no bending, straining, no heavy lifting, nothing where he holds his breaths and squeezes.
Okay.
6 weeks would be ideal. 3 to 4 weeks is really critical.
So this is the first time you've spoken since then?
Yeah, I've been on complete voice rest since, so I
Okay.
didn't even know what would come out of my mouth today.
Well, let's do this. Let's go 1, 2, 3, 4, 5. Speak up for me. Start low and ascend.
Yeah, help me set boundaries because I'm a little anxious about overusing.
Just you know what? Joanna will do that for you.
Okay.
I'm just going to check the range right now.
1, 2, 3, 4, 5.
Yeah, don't force it down.
The voice therapy is critical following the surgery because the surgery hands you the toolbox
You hear how good he sounds?
again.
Yeah.
The voice therapist
There's cup
teaches you
bubbles.
how to use the tools again.
People's recovery from this surgery varies a lot. Many of our patients have no swelling and their voices are normal at the end of surgery and they're still normal a week later. Mr. Mann took a little while to recover, but he has gotten better and better and is continuing to get better. Relax. Good. You're making good progress. You still have some swelling in there. It's going to
Really?
go down and continue to get better still.
Good. Not because it's pretty, but because it says something to us that we long to hear, that no matter who we are or what we are, there is still one person who will come in and sit down next to us and be with us just the way we are. I did the whole service today. It's the first time I've been able to do a service all by myself in a long, long time.
This is my story, this is my song, praising my Savior all the day long.
I can rely on my voice now. I mean, I use my voice professionally, so not to have my voice means that I would not be able to do my job. And in a real sense, I feel like Dr. Sadaloff has given that back to me.
Change my heart, oh God, may I be like you.
There is very little that is more fun than taking somebody like Mr. Mann, who is struggling just to get by, working with him, operating on him when necessary, and then working with him again. And then seeing him go back to his life with his...
It's just, a commercial of sorts. Okay, so I think, let me get out of this. I think that was it. So I have, this is who you go to. I'll put it this way, okay? Down at Philadelphia ENT, with who I work with Robert Sadaloff and Guillermo Lori. Fantastic. Aaron Jaworek up at Lehigh Valley. He is getting so busy now. He's the first laryngologist they have that now they're looking to hire another one, and they're actually interviewing the current fellow we have in Philadelphia. So I'm kind of hoping, okay, that he ends up there with Aaron. He's gotten so busy. He was one of our fellows 7 years ago, I think, that it's like a 3-month wait to get in for him now. So he's hit that kind of problem as well. Hassan Paknazad, he was another one of our fellows. He's with the Geisinger network, so a little more north, a little bit more west. John Romack, he's down towards, he's in Delaware. If we have anybody who comes down from that area. And of course, Joseph Spiegel, who just is a legend just in himself, Jefferson, okay? And we hope to keep adding more and more and more. So we have more voice specialists for people who need them. So that's all I have. Thank you. Okay, what do we do? You can always ask me questions privately after if you want. Yeah. Mhm.
30 minutes without starting to use my voice.
Mhm.
I just assume that that's just, it's out of practice and I need to get it back exact.
Yeah, that is a lot of it because you did get it back, right?
So
Yeah. Yeah, that's usually a lot of it when you're not used to talking for long periods of time. And then you build it back up. Yeah, that's not unusual. Yeah. Krista.
I'm just wondering, when the patient with the Gore-Tex that was put in,
Uh-huh.
how long does that last? Like, how long does it?
For the rest of his life.
Really?
Yeah.
That's amazing.
Yeah, now occasionally, if someone's not very careful while they're healing in this, you can have the vortex shift and start protruding. So then there has to be a revision done. You have to go back in and fix that. That doesn't happen commonly. That's not a common thing. But no, that stays in there for the rest of his life, unless it's not working and then he just goes in and takes it out.
And it just fills in the spot where.
That's all it does. It just moves everything over. Yeah. That's done more for people who have nerve injuries. You know, when the nerve is not allowing it to come over as far. So all you do is just physically find a way to push it. So the nerve will still work the same way, but there's more of a body there being pushed.
It's pretty amazing.
Yeah, it is. It's fantastic stuff. I was feeling homesick for that's Hahnemann before, long before it closed. And that's where I always used to go down every other Monday for surgery. Yeah. So I'm like, oh, yeah.
And is this Dr. Saddlebaugh the one who pioneered that?
He's one. Yeah. He's come up with many brand new things that are done. He's essentially the most famous voice doctor in the world. He's the one I learned about when I was 20, when my mother threatened, 26, when my mother threatened to take me down to him. So no, you can look him up online. You'll get the whole history of what he's done. His father was just as famous when it came to ears and hearing, and was actually an advisor to Nixon in getting OSHA set up. So it's a long historical, famous practice in Philadelphia. So the other one thing I just did want to say, my students know this, but it's time for faculty to know, okay? If you ever are worried about your voice, if you think something's not right, let me know, I can help, okay? And I'm happy to do it. I can at least, I can hear you and kind of tell what's going on. I can get a little bit of the background. And I also, because I know these folks, I have kind of like an in, okay? With our own students here at KU, I make the appointments for them down there. So if they are especially tricky, I make their appointments, and I'm down there on Wednesdays. So, if you find it, you have to go down there, make your appointment for Wednesday. And I'll be in there with you. Okay. No, I mean, I've been in the operating room with some of our students, when they're undergoing, and so I'm there right there with them. And I'm the first thing they see when they wake up. Talk about frightening. Yeah. Okay. All right. Well, okay. Thank you.